Thank you, Dr. Grover, and to Milan and Shubes and Kastori for a wonderful program. And I'm really honored to be here, and I hope we can return the favor to all of you soon. I'm talking today about lower rhytidectomies, and some of you in ophthalmology are like, what are we doing here? But honestly, we have such well-trained oculoplastic surgeons now coming back to India that we're starting to see neck and jowl lifts and some really beautiful results. And I certainly also think that, you know, when we're doing cosmetic surgery, particularly on the eyelids, we really are the doctors to do it, because we really are the people who know the eyes. I just finished a study with Allergan. That's my disclosure. And today what I'd like to do is, let's say you didn't know anything about neck and jowl. What I'm going to try to do is give you kind of a 101 course in it. Look a little bit at the history, the pertinent anatomy, clinical evaluation. And this is a little more aggressive than what Dr. Rose has shown you. He went through all of the history of BC, and there are very, very few historical details because a lot of it was private. But the articles on lower facelift have come out of Germany and French. The techniques were very guarded, and it was mostly just subcutaneous underlining and picking up. But the first published article was out of Germany in 1901, and Eugen Hollander operated on a famous Polish diplomat and then wrote an article on it. And then later, in 1926, Suzanne Noël, who was French, and she was married to a surgeon. She was a dermatologist. He died. She took over his practice, and she wrote a handbook in 1926 on neck and jowl lifts called La Chirurgie Esthétique, son rôle social. So here's what you need to know if you're going to start. And I have 40 articles that you need to read. And I have them, and you can email me, and my email is down here someplace. In 1950, the classic facelift was written about. That was Swanker. And then in 74, it was Skoog, who described a subfacial dissection. 76 Mitz and Peroni were the ones who named SMAS, the submuscular aponeurosis system. And then in the 70s and 80s, there was a lot of controversy about, is it a short flap, is it a long flap? And now today, what we're doing is we're doing an S-lifting, which John showed you, Dr. Rose did. We're doing SMASectomies, SMAS plications, going into the deep plane. But today I'm going to be sort of talking about the SMAS plication, and I'll tell you why in a minute. But the SMAS is a distinct fascial layer, and it goes from literally the platysma to the frontalis. It is discontinuous at the zygoma and envelops the zygomaticus major. There are certain septal connections to the skin, and what's interesting if you plan to do this, those septal connections are very important to leave. New studies in the last year have shown that leaving those connections improve outcome. This was a study done at Manhattan Eye and Ear in 2004, and this is a set of 4 twins. And this is a pre-op, this is 1 year post-op, 6 years post-op, and 10 years post-op. And there were 4 different surgeons, and what they determined in this study was that there was no technique for the lower face that really made a difference. Meaning if you go deep, if you stay more superficial. Ron Strahan and Kathy Wang at Jowl Stein Eye Institute basically reviewed 400 in our institute and found mostly that the biggest problem was that people were not addressing the mid-face. So here's an example of an actor, Clint Eastwood. Maybe you know him, maybe you don't. Another. And we're seeing a face that loses volume like a balloon that deflates. And this is someone you probably know. He's the governor of California. This is Arnold Schwarzenegger at 20, and here he is at 60. So there is a deflationary process, but there's also a gravitational process as well. And this is very complicated, and we'll hear many more studies in the future. But when you're dealing with someone who wants cosmetic, you really have to do a history, just like anything else, any diagnostic criteria that you're doing. You want to know, are they a smoker, diabetic, hypertension, are they on aspirin, steroids, vitamin E, etc. And then with the lower neck, there is a grading scale. And that grading scale involves not only the bone and the framework, but also the soft tissue and the skin. So there are a lot of different classifications of the neck, but I think the one that sort of works, if you're going to decide this, and there are a number of articles on this, Class 1 neck is a neck that's essentially normal. It has a good mental angle, there's good skin tone, and the platysma does not have any cording. Class 2 shows laxity of the cervical skin without any fat deposition or muscle pathology. And this is an example of someone who might be a grade 1. You would never do a lower neck and jowl, but you could add volume. You could do a little of the fillers or whatever, and this would be a result. Another example of a grade 2 for volume replacement, which would be good. A class 3 or 4, this is where you begin to have some subcutaneous fat, which is either genetic or acquired, and liposuction is usually required to improve the cervical contour. The other thing is you can see cording there. Class 5 and 6 is where you have retrognathia, and that contributes to the neck pathology. The other thing is when the hyoid bone sits low, or when the mandible and the hyoid sit low, you really have to educate the patient about the results, because it is not an optimal procedure. So let's just look at the anatomy here. When we look at the mimetic muscles of the face, if you think about it, and Rose wrote about this a couple of years ago, which is ajsconline.org, but think about it in sort of layers. So what we have is we have the orbicularis oculi muscle and the superficial zygomatic minor here, and the depressor angularis. And those are sort of the most superficial. Secondary, we have the platysma, the risorius, the deep minor, and the major zygomatic. The third layer, the levator labii superioris and the orbicularis oculi. And then again, deeper levator anguli oris, which sits from here. But the, let me just see here. And again, the deepest of all is the buccinator, the levator anguli oris, and the mentalis. And this is a nice diagram just showing the different layers of the muscles in the facial area. What's crucial to understand if you're going to do or consider neck and jowl lifts is the facial nerve as it exits the sternomastic foramen and emerges deep. And right in front of the ear, in the pretragal area, it sits about 3 to 3.1 millimeters deep. And we have these papers if you'd like to see them. And then that nerve sits deep to the parotid fascia, but it becomes more superficial as it leaves the parotid going anteriorly. So superficial distal temporal, lower buccal, and upper mandibular branches over the masseter muscle and the marginal mandibular are what we need to understand. So when we're looking here, we have a 2-centimeter rule, and studies have shown us that from the tragus forward to the anterior edge of the parotid is about 38 millimeters. Don't forget about knowing about the ligamentous structures, the zygomatic cutaneous ligaments, the mandibular cutaneous ligaments, as well as the parotid mesenteric ligaments. Okay. So let's say you're going to examine someone for a lower face. Look at the bony structure. Is it protruding? Is it small, normal, large? What about those adipose deposits in that submandibular area? And you can grade those. We always look at the submaxillary glands because, as Dr. Rose said, we're not going to have or improve those. What's the skin? Is it relaxed? Is it ptotic? What are those rhytids? Can we grade those? Do we have anterior cords or secondary cords? And we have adjunctive procedures, laser peels, dermabrasion, chemical peel, neck treatments, implants, blepharoplasty, etc. But I think the most important thing is to really let your patients understand that where that hyoid sits depends on that cervical mental angle. And so that's something that we really can address. And this is an example of someone who really is going to have a problem post-operatively because she has a recessed chin, she has a low hyoid, and her mandible sits low. Look at the patient's desires, self-image, anxiety, fears, and if there's any doubt, don't operate. I'm kind of at the point in my career where it's not who you operate on, but it's who you don't operate on. We do the pre-op marking with the patient there. I always ask to look at old photographs. We look at those platysma bands, and obviously anesthesia is either local or with some mild sedation. Develop an operative plan and really look at those old photographs and show those and have a discussion with your patients. Pain meds and our instruction sheet. Here's my email if you guys want the 20 or 30 standard articles that are important to learn this. And then in our operative technique for this is a little bit of a longer incision, but I use the rule of C's, and that is something that Dr. Strahan and many others have taught me. If you think of the ear as like straight, that's not exactly the best way to make an incision. So we initially tumesce with the standard tumescence that Dr. Rose did, and then those rules of C's are literally a C, a C, a C, a C, a C. And that incision is at the back of the helix here where the hairline meets. There are some who take that incision down. There is more skin that you can get, but I don't think that gives you often great scarring. Our technique is a subcutaneous undermining. We go out to 2 centimeters before the oral commissure and into the zygomatic ligaments. And that is all done subcutaneously, and you're safe because the facial nerve is not there. Then what we're seeing is we're looking at, here we on slide left, we are suturing to the posterior platysma. And there's a wonderful little technique where you can suture from the mastoid bone and do a small suture into the posterior platysma and back through and tie with 2 to 3 sutures in a sort of serpentine fashion. Our adjunctive procedures are often squeezed fat to add volume. And then we go ahead and trim in the same way that we have made those C incisions. The SMAS then is lifted in a plication or in an ectomy where and this might be different. So let's say you have a thin patient. You probably would do a plication. If your patient is larger and there's a larger face, you would probably do a SMASectomy. And here's an example of the posterior platysma where we have done a SMASectomy. Again, the skin is pulled. I'm not going to go into an anterior platysmoplasty, and again, a pre-op and a post-op patient. I'm going to show you a few slides. I thank Dr. Goldberg for giving that lecture today. I think post-operative and pre-operative photographs are very, very important. We do not put in drains. Patients are also given pain medication and instruction sheets. Pixie ears are a common problem. Hematoma, skin slough, earlobe deformities, obviously, infections, widening of scars. And nerve injury is the most important, but I think by understanding this, and here are some of my earlier, and this is also one of Dr. Strahan's. Here's the patient. She ended up having a chin implant, a large round face. So please feel free to understand and learn the anatomy here, and thank you for this.